Good afternoon, everyone. Thank you for coming today. Today is learning session number 4. We were doing sessions about the ROSC, which is the Recovery and Resiliency Oriented System of Care. The first session we did was What's the Problem? And we talked about what the problem was with alcohol, tobacco, and other drugs for the Monadnock region. And then we had a session on prevention. And we had a session on intervention, treatment, and recovery supports. And today we're talking about integrated systems, and I have a panel of guests. And to start us off today, we're going to have Rudy Fedrizzi come and speak, and then I'll have each of the panelists introduce themselves so as to get their names and titles correct. Rudy.
Thank you, Polly. But first, we have a little presentation to make.
So our dear Polly Morris is leaving us. She's accepted a position which was created for her up in Plymouth, doing very similar work. And Dennis was thoughtful enough to get you a bouquet to show you how much we really appreciate what you've done here in this region. Some outstanding work in a real short amount of time. I don't know of anyone else that could have pulled it off like you did. So thank you so much.
Thank you.
So very sweet, and I know that Natalie's tired of hearing this, but I keep saying this is not the last of me in the Monadnock region. I love it here, I love my job, and I'm thinking of it as extending the partnership and making it broader, and that's all. So I will still be around. You will still hear from me, but thank you, this is very sweet.
So we have about 20 minutes together, and then we'll get to the panel. The computer is acting up, and so you have the slides in front of you. We may end up having to refer to them. Sorry, they're so small in a handout format. But what I'm talking about is the model of clinical community integration that we've been evolving at Cheshire Medical Center, Dartmouth Hitchcock Keene, and as part of Healthy Monadnock 2020. That model is different than the model that I'll also touch on, which is the model of primary care behavioral health integration. So we'll touch on both of them. I hope they're not confusing, but I think if we have a lively conversation around this idea of not one of us can solve the problems that we're facing alone. We have to do it in a collective way, and this concept of integration is one potential way. So I found this really interesting cartoon that says, I'm going to read all the slides to you word for word until you want to die. So I'm going to try not to do that, but the slides are for each of you in case there's some details on the slide that that I don't touch on that you want to take with you. So the idea of integration, we first have to talk a little bit about why we might want to integrate, and then what does it mean to integrate. I think we'll talk a little bit about how one might integrate, or how others have integrated, or how for other activities we've begun the integration process. And then ultimately, when might we imagine creating the optimal integrated system that we desire? And what are the barriers or opportunities that present themselves? So that's kind of the agenda. We face enormous problems as a community and as a society. These are just the key issues of Healthy Monadnock 2020. Obviously, there are many more in the community. But when you think about the social issues, the health behavioral issues, the health status issues, and the issues of social belonging and connectiveness, this is a huge undertaking. And in order to do that, address that, we need to think of how to do that together. Not one of us, the hospital alone certainly can't impact the health of the community as it would desire, and no one of your partner agencies can either. And so the whole idea of integration really arises from the idea that the problems we're confronting are enormous, and it's going to take all of us pitching in. I'm sorry how distracting that can be. Why integration is partly because you can't trust physicians, right? So I'm an OBGYN by training, practiced clinically for 17 years until 2010 when I took the job at Cheshire Medical as Director of Community Health Clinical Integration. But realized that back in the 50s, physicians were actually advertising on the side of advertising for tobacco. So the medical establishment, it has a track record of not solving problems, right, alone. So it can't be only a medical issue, and this slide always reminds me of that. You probably have seen this before. I thought maybe there's a way to fix that. The contribution of health care delivery is only about 15 to 20% of our health. The other 80% are a wide variety of factors, many of which are social. Educational attainment, income and jobs, safety, the environment, people's own lifestyle choices and constitutional factors, even genetics. Those all play into health. And when you think of health and think of any particular issue, like we're talking about an issue around substance misuse and abuse, if you think about it from the lens of this sort of socio-ecological approach, all the factors that influence health, it's really eye-opening. And for the medical community, my role is really one of reminding or reinforcing the fact that health is influenced and impacted by many things, not just the care that's being received in a one-on-one interaction with a clinician or caregiver. So if we believe all that, that health is complicated, it's influenced by multiple factors, no one entity can solve it alone, then we need to be thinking of solutions that are different than any solution we've thought of before. I can be somewhat controversial when I talk about this because I think whatever we've been doing for the past 30, 40, 50 years in health hasn't worked. So I don't want to hear that public health is wonderful and back in the 50s and 60s they were able to start to tackle this problem or that problem. We live a lot on our laurels and not on the present day and how we're impacting. So to pick tobacco, huge strides in tobacco since the 1950s and 60s. Very little being done in the last decade or two, right? So if we keep saying, well, but we're going to just keep, doing more of what we were doing before, my feeling is that we'll get more of the same, which is not very much health improvement. So I think integration, you'll see, is a very different way to think about confronting our health issues, and it's one whose sort of time has come. This is a slide that I use quite frequently. If you've ever heard me talk before, you know that I use this quite frequently. I was trained as an obstetrician and gynecologist to rescue people when they were in crisis. Occasionally, I got to be part of a normal pregnancy and birth. That was wonderful. But most of the time, I was paid or paged for catastrophes that needed to be addressed. So much of the current and past medical establishment has been geared towards rescue, right? People have a problem, we respond to that problem, I get paid for that problem, they feel better for a little while from that problem. None of that has to do with improving overall health for individual or their community. Right? Yet that was the model that we all were trained in and still are trained in for the most part. And we're still paid in. So even though there are other payment ideas coming, and you'll see that integration will require there to be payment reform, because the current payment model, which is pay for crises, won't work when we're talking about prevention. Right? So this is the old model. I thought I was integrated before I took this job with the community, because I always had the fullest rack of brochures that I could possibly have in my office, right? So if you had trouble with your breastfeeding, get out the office and go to the rack and pull out the card that was there from the Cooperative Extension or from the La Leche League or from the WIC office. Get some help with the community. I'm thrilled that there are community partners helping women achieve success with breastfeeding. That was that was the extent of my integration with the community, right? Or I had my poor receptionist on the phone doing all the 1,000 things she had to do, checking if she could find a partner organization that could help a person with a particular problem. And a good example for that was occasionally we'd have a person come in and tell us that they felt unsafe in their living environment. And I would say, this is a person right now, we need to find her safe shelter. And someone would get on the phone and call around all the things, look at the white pages and yellow pages. And so it was brochures and the phone. And that's not a very seamless way to integrate services for our community or individual patient. So this model is not the model we're talking about. The model we're talking about is what we call big I integration. And big I integration means, could we create a relationship for the betterment of health that would link seamlessly providers, healthcare providers, public health, community partners, many of which are in the social service agency world, and individual patients themselves who would both understand and demand this type of integration. Could we build that? So if you read the literature on integration, most people say integration has to do with getting along. Like the hospital, we're fortunate in Cheshire County that our hospital and our provider group are one and the same. They're under a single umbrella, and they're two nonprofits that are joined in a very special way. But most of the time, that's not the case. When I practiced in Ithaca, New York, before moving here, I had my own private practice, distinct from the hospital. So integration would have been something like me playing nice with the hospital. Like I'll sit on some committees at the hospital. I'm integrated with them. They may help to send laboratory reports directly into my office EMR system. We're integrated. That's not what we're talking about. We're not talking about getting along peacefully. We're not talking about what my department does through Chelsea Saber, which is do community outreach and do community programming. So now the hospital is integrated with community because we're offering some health education opportunities to the community. That's not, I mean, some people call that integration. You're trying to integrate with the community. That's more connecting with the community. Some people say integration really means merging. You have to buy things. So as hospitals buy physician practices, they sort of by definition now are integrated because they become employers of one another. You know, employees are employers of one another. That's not really what we're talking about. We're talking about building a system of health where all of us are on the same page with coordinated activity. So it looks something like this. Oh, I'm sorry, one other thing before I get there. Integrative medicine is another word that gets confusing. And integrative medicine means Western medicine, the kind of medicine we're taught in medical schools, could be enhanced with complementary types of care opportunities like yoga, massage, acupuncture, certain kinds of counseling, spiritual connection, things of that nature. Again, that's an integrative approach, but not what we're talking about in a useful one. But what we're talking about is this model. And I'm sorry that you can't see this model. But if you can imagine that the public health world, or in our community, because we really don't have a public health department, it's the community health world, and medicine, which would be on that side of the right side of your screen. Right now, or traditionally, they've been siloed. They've lived apart. They've competed in some ways for money and for resources. And one of them always wins in terms of both attention and dollars, and that's the health establishment, right? You've probably seen slides that show that 88 cents of every health dollar goes into the traditional medical model of care, treatment, diagnosis, testing, and about 4 cents of every dollar ends up in the public health arena, prevention, protection of health. Pretty lopsided, right? This model asks, can we imagine a future where the medical community embeds itself in some ways, and I don't necessarily mean co-located in spaces, but it expects itself to be involved in every aspect of care, from the farthest, most intensive medical care that people need in an intensive care environment, all the way out to the policy environment, where they're advocating for changes in schools or laws or things of that nature. And could we imagine having the public health or community health world thinking and knowing they have a role in every aspect of a person's care, all the way to the point of them in the most fragile of patients? So an example would be a partnership that we piloted with HCS around advanced care planning, right? That we in the medical establishment need patients in the very end of their life to make choices that are consistent with their values at the very end of their life. But we don't necessarily have to be the ones to deliver that service. That service could be delivered by the community and help the medical establishment to have clear direction from a patient and family about their end of care needs. So this would be where we both sort of be in each other's business because we both need to be, right? If we were to do that, imagine that, then there's a continuum of care from the most medically fragile all the way to folks that aren't even ill, but just need to be protected from becoming so. And all of them would be served in this model by sort of all the folks that could influence health. And if you add to that the patients themselves being in some way activated, desiring this, knowing this is important, expecting that when their care is delivered in an inpatient setting in the hospital, they're going to be seamlessly connected to services in the community as part of their extension of their care. That's this model of integration that we've been working on. And is part of what sort of underpins all of Healthy Monadnock's work. What's missing maybe from this is sort of the advocacy and outreach work of individual organizational partners of Healthy Monadnock, but all the delivery of services and care is captured in this model, or could be. So, the simplest way to show this is the idea of alignment. When you are resource limited, there's not unlimited people, there's not unlimited money, and there's not necessarily unlimited social capital or connection or relationship, then the first step is really alignment. We're all doing good work. Can we all get on the same page? Can we all row together in the same boat, all towards the same goal? And if we can get that, it doesn't mean we have to give up any of our own autonomy. It doesn't mean we have to give up any of our own grant sources. It just means, can we all get on the same page? So some folks would say collective impact is really this model, and this just predates collective impact, but the idea of this mutually reinforcing activities. Can we do mutually reinforcing activities with consistent goals, consistent measures of outcome, and do it better than we're doing it when we're all fragmented and separate? And that's another way to show integration. I'm going to use a copy of my notes so I know where we are. So there are key elements of integration, and these have been described in all this is available to you from me if any of this, the details matter to you. But there are certain things where integration really works. So if you need your appendix out, that one you can pretty much go to the hospital and have your appendix taken out. You don't need a terrible, sophisticated degree of integration for that. You just need to get to the hospital and have your appendix taken out. But for other problems that are socially complex, require a population-level intervention, those are the ones that are most necessary with this integration model. So the elements of integration are things like the problem's so complex not one entity can deal with it themselves. That there is a shared vision that we can agree on. There are shared measures that will help us to know where we're headed and when we'll know we're successful. We have the relationships built up to at least start the dialogue about how can we build these kinds of structures. There are best practices that we'd all agree on and that each of us would have a role in. Things like that really help to facilitate integration. There's a stepwise model of degrees of integration that we've devised that takes us from just sort of agreeing on a vision all the way up to what we call accountable integration, where we really could be merged as entities, or we really could be co-located of services in each other's entities. This stepwise, stairwise graphic shows you that, and we try to understand each of our integrated activities along this stepwise, stairwise continuum. Are we really just sort of agreeing that this is a problem in town, but none of us have done anything collectively yet, all the way through a partnership relationship to the point where we're actually starting to share resources and people's time and even sharing the messaging. So you'll see in a second that there's another model of integration that is similar to this, but this is the one we use in town. 5 steps to reach sort of full integration. So I sort of want to stop there to say that's our community clinical integration model. It's a model of everyone comes together to solve a problem collectively. Shared vision, shared outcome, shared measures, avoidance of duplication, and the patients themselves are engaged in understanding that that's what's happening, so that they at some point see all of our interactions with them as part of a continuum of their care in a whole. SAMHSA has a model of integration, particularly around this problem of behavioral health and substance misuse, that is a little different. And their model is medical behavioral health integration. So this model, I try to end this talking part, and then we can have discussion with SAMHSA's model. Now, the amazing thing about SAMHSA's model is the individual who is most important in coming up with this idea of behavioral health integration has just joined the faculty at Antioch, a real national leader, a guy named Sandy Blount. And in the early 2000s, he came up with a model of integration that is displayed on, and I'm sorry you wouldn't be able to see it, it's so tiny, but it's really 3 elements in how medicine and behavioral health could be integrated. One is that we're sort of coordinated. And he would say the important thing in that model is communication, that there's more seamless and positive communication in a coordinated amount of integration between those 2 entities of medicine and behavioral health. His middle one is co-location. In that one, he says there's physical proximity. We're in each other's buildings. Our buildings are shared. That level of integration in his model is more sophisticated than just sort of talking out care needs more positively. This one is we actually live in close proximity. And his third one he considers full integration. And in that part of his model, people are making changes in their practice style. For instance, in every single time there's an interaction with a patient, we might do an SBIRT assessment, and depending on the outcome of the SBIRT assessment, the patient is immediately interacts with a person who can help them with that brief therapy, that brief intervention, all in the same visit, because the practice delivery has been changed. Not just that we're close to each other and we're down the hall, but we actually anticipate you might have more than one person interacting with you in this visit, depending on your need. So Sandy comes up with this idea. SAMHSA's embraced it in their Center for Integrated Health, and it's the one you see on the bottom right of page 3. And it very well connects to our model of integration. It just doesn't go out into the community or to the individual patient. It's really meant to get the entities together. What we would advise to, and we'll talk with him when we finally meet him, is to say, we've got this whole eager, connected community ready to help whatever the medicine and behavioral health folks can do in terms of linking their service delivery better. So we tested that in the past year. That's the slide actually the slide to the left of the slide I was just speaking to on page 3. This was a year-long project that we participated in with MFS, Phoenix House, Cheshire Medical, and a variety of other partners like MVP, around the idea of, could we actualize this bigger model of integration, including the SAMHSA one and our community one, around prescription drug misuse and abuse. So for the past year, we've been working together on that, talking about how do those 3 entities move along the integration continuum that Dr. Blount has described of communicating, co-locating, ultimately changing the way we deliver care, while at the same time understanding that we have a community of support that we can link to, as well as individuals understanding and expecting this kind of coordinated care. So that was a year-long process that's just wrapping up, and you'll learn about that through the kind of reporting we do. We're now sort of looking for funds for implementation. So the last thing I wanted to leave with is this idea of, well, when can this possibly happen? What a great idea that we might all be on the same page, all with the same shared vision and values around caring for people who have need, compared to the fragmented system that we've been working in that isn't working. So there's an idea in public health or population health called the triple aim, that could we figure out a way to deliver excellent care, both for the patients and families, but also from the perspective of the caregiver. So we want caregivers to enjoy their work and feel that their work is meaningful and satisfying. Could we improve people's health measurably? And could we do it for less cost than this current fragmented system is now? And if we could do that, could some of the savings from that no longer being spent in the treatment and diagnosis and rescue aspects of medicine, but in the upstream social and prevention places, could that money be reinvested in those sorts of activities rather than in rescue? And that's sort of our triple aim of what we're imagining and trying to build to sustain this sort of good idea. Because right now, the payment model is still, come to me with a problem. If I can interact with you for 15 minutes and address that problem, I'm going to get paid. Whether that addresses your full health needs or not, who knows? Whether it addresses any other needs outside of health but are just as important to your outcome, don't have any way to pay for that. That system is just, the fee-for-service system has to change. So the last three slides that you have there are from the 2014 Endowment for Health study of medical behavioral health integration, a really great study that was done in New Hampshire for talking about the desires, challenges, and opportunities around doing this medicine behavioral health integration. It talks about we're going to need a shared way to communicate by IT, for instance. We're going to need confidentiality tools that transcend the entity that you happen to start with, this idea of no wrong door. You know, if you start your care with the hospital, then whatever we do in terms of our consent of that individual ought to help them receive seamless care in a treatment environment or a mental health environment without the hassles of privacy. And all those things are understood in those three slides about the sort of needs and opportunities. The green brochure that you have is a brochure that in less than 1,000 words explains our broad model of integration of medicine, public health, community partners, and individuals, and gives some examples that are not related to our talk today, but talk about youth health and tobacco. But I think it's a good primer for here's what the model we have in mind. We're in little ways already operationalizing it, but these are little ways because right now the payment hasn't reached the point of supporting our desire. But my role at the hospital is to see this through. And so I can tell you that the hospital and the clinic is very eager and interested in being part of the solution of all of these challenges we have. And in the future, if they haven't been in the past, will be more eager to partner in meaningful and connected ways to better meet the patient's needs. And the hospital very much understands that the goal is to keep people out of the medical environment. And so it's, they're going to have to change their business model, which up until now is fill the place, test everyone, prescribe for everyone, because that's the economic model. And I think that's changing for the better. So thank you very much for that. I'm sorry about the technical aspects, but I'll take questions with the panel when that's appropriate. Thank you.
turn this off. Is that turn it off by itself?
Yeah.
So thank you very much, Rudy. That was very informative. I'm sorry for the technical difficulties. So the whole idea of integrated systems in the Monadnock region is we have this larger public health advisory council, and we have a community health improvement plan that we're working on with the priorities for the region. And all the regions in the state are asked to do 5 priorities. But the Monadnock region, being the way we are, decided to do 11 priorities, one to include mental health. And so talking about the integrated systems, that whole larger oversight body, and trying to get all the people in the region to be all working on the same page in the same direction and communicating and having the no wrong door services is I feel like that's where we're moving. So to carry on the rest of our conversation, I've asked several folks to come and talk about the integrated systems work that they're doing in the region, because we have several different things happening, and hopefully we're all moving in that direction to the larger goal of having one unified system. So I've asked Jude Grofier to come, Dennis Calcutt, Kate Robertson, and Natalie Nielsen to follow Rudy with a little bit about what they're doing in their community for systems work and what their role is and what their vision might be for the future.
So like Polly said, my name is Jude Grofier. I'm the programming coordinator at Monadnock Area Peer Support Agency.
I'm Dennis Calcutt. I'm the project manager for the Monadnock Region System of Care Planning Grant.
My name is Kate Robertson, and I am an outpatient counselor in Keene, and I also work here at Cheshire County Department of Corrections. I provide outpatient or individual services here, and I also run recovery groups.
And I'm Natalie Nielsen, and I work at Monadnock Voices for Prevention as the Continuum of Care Facilitator for the Monadnock region.
So Jude, go ahead and start.
So one of the things that we were asked to do in preparing for being a part of this panel was to sort of talk about our role with the ROSC and sort of our vision. So I'll start right at that spot. If you're thinking about ROSC, you're thinking about it in terms of the treatment, recovery supports, prevention, intervention. And while Monadnock Peer Support doesn't fall within the treatment, the treatment part of things, we fall within recovery supports, we fall within intervention, and we fall within prevention. So it's those sorts of things that we're coming together. I think as we get further into the conversation, I'll be able to share some examples of that. I think that Rudy started us off with a really cohesive overview of a lot of information that I was aware of but didn't quite know all the details about. So that was definitely very helpful for me. Do the rest of you want to share kind of your vision or where you fit in this?
Sure. We are, in many respects, developing the vision of where we think the system of care approach for children or youth with significant emotional and behavioral health needs is. And I really appreciate what you said as well, Rudy, from the perspective of integration. And it's not that aspect of, we just talk to each other. It really is, and I think in many respects, it's how we get along. And a lot of that will come down to, in my mind, can we focus on the need? And if we can really focus on the need, a lot of times the adults can put aside their issues, because I do think the adults at times clog the system. And then who suffers in this process? The nice piece about what Rudy has touched on, as well as some of the values from the system of care approach, because this grant is also funded through the Substance Abuse and Mental Health Services Administration, it's really about how do you bring that family, that youth to the process and have them driving that process. I think I don't know the right way to say it, the physical health world or the traditional health world has done that already in some respects. All of us, when we have gone to the doctor, in many respects, we are part of that process, and I think we can engage in that process, or at least the process seems to be that way. I think the struggle for the populations that we're thinking about touching here, and specifically mental health, a lot of that really gets For some reason, it's changed. I don't know what those barriers, all those barriers, I know some of them, but some of it is really about the fact that as a structure, we haven't always included those people at the table. They haven't been involved in this and driven that process. And I see that in the work that you've touched on here, Rudy, as a key component with integration and bringing those people here. And it's really, the piece that I'm thrilled about to be one living in this region and working in this region is all of the potential that's out there. I sort of describe it like a Yankee magazine effect of you open up Yankee magazine, you look at the one story, which is maybe 2-3 pages long, and you think, oh, that'd be a great community to live in. And that might be only like a weekend a year in that community, but it highlights what that is. And I think we're very fortunate to have so much going on right now. And I think the real key is how we all will come together. And I think the model that you've described here with that integration and knowing that it's going to be difficult and noting that and speaking to that, but then also bringing in these new ideas. And I would say from a mental health perspective with the youth voice here, that has been the area that's the slowest to come along. And I think it's societal with stigma. I think it is also, the nice piece is the recovery movement is a step ahead. And I think that's been great. People in recovery have been able to say that they're in recovery and be accepted for, that's an accepted component, and that's fine. But people with mental health issues, it's still not there. So how we help bring that into the picture is important. And I think the other thing that I think that happens with integration is if we can be really focused and really come down to what are the areas where we can pilot some things. And that's what in this grant, we're trying to focus on is can we pilot a couple things that will hopefully identify some success and see how we can broaden that and carry that to other parts of the region will be important.
So my role obviously is as a provider of services, and I have a pretty huge vision actually for ROSC in our region, and a part of it is inspired by all the fantastic leadership we have, and knowing that given the level of passion and dedication for the people that are involved in this, that we can actually achieve it. I know some of the areas that I see the most need in is definitely recovery housing, transitional living, safe spaces, working here at the jail, working with a lot of individuals who are getting released and they don't have a safe place to go, so they end up in some pretty risky situations. That is a real genuine concern that many of us have, including the individuals who are leaving without the supports that they need. I think that ideally what we will do as a region is create safe spaces where people can just walk in the door and be wherever they might be in their recovery journey. It's not an abstinence-based, mindset that if people are still in the part of their lives where they're not quite ready to let go of alcohol and other drugs, that we still provide them the compassion, the loving kindness, and help them move into that recovery journey. And I think that having spaces like that will create a much more welcoming environment for people and help them move more towards wellness in their own lives. Treatment capacity, I think we need to definitely address that in this area. I know as an individual, I could easily probably triple my caseload right now, but I don't have the time. And being able to find referrals for people has been definitely a struggle. And I think that it would be just an amazing experience to have enough spaces for people so that when they're in that moment of it's time for me to make some changes, they can actually walk in the door somewhere and have those services available. Natalie and I actually were talking, so I'm going to share a little bit about what we were discussing before this panel started. And a piece of that is having the relationships with individuals and then also with other providers. So, in addition to working with somebody and knowing that they might need other services, to actually have warm handoffs where we have a whole system where it's not just handing a business card to the individual, but actually either walking them over to the office or having some kind kind of connection that's a little more personal and a little more tailored to what their needs are. I would love to see wellness programs in the schools starting at a very young age, integrating mindfulness practices, prevention, having prevention programs that really target the age of, being age appropriate, talking about alcohol, tobacco, and other drugs. The younger the better is what research has shown, and I would love to see that in our school system. And at the end of all of these conversations that we're having, having a common understanding of what addiction is, because I think that there clearly are multiple levels of stigma that still occur. And I think that is internalized by the individuals who have addiction disorders, as well as providers who are trying to work with people who can be very difficult at times to engage in that process. And so I think as a community, we can create this sense of working with people who need certain services and address any stigma that may be there with them as well as within ourselves. I think that would be just an amazing thing for us to be able to provide. And just as a final thought about the idea of silos, what's interesting is I transitioned not too long ago from a residential setting now to an outpatient practice, and my experience has been how easy it is for me to experience that silo, because my time is very focused, fee for service, so I don't have a lot of time to connect with others, which is why I really appreciate this opportunity to come here and meet everybody and talk about it. But so in a way, the system itself creates those silos, even though we talk about breaking them down. And I think that I really would love for that to be a part of what our solution is. How do we as individuals kind of create these spaces where we don't have to operate in those silos, and we're able to connect on a different level. So,
as you may have realized, I have not been at the other learning sessions because I'm brand new. I'm 2 months into my position, so I did want to speak a little bit about my unique role and how not so much the work that I've done thus far, but the work that I plan to be doing. In speaking of, and in full transparency, I wrote what I was going to say down because I didn't want to forget anything. As we're speaking about integrated care, I did, and it's been mentioned and is in your workbooks, but we've been talking about the ROSC, and I'd like to relate it to what I've been doing and exactly what it is for anyone that's not familiar completely. But the ROSC is the Resilience and Recovery Oriented Systems of Care, and that's a coordinated network of systems, services, and supports along the continuum of care. So that incorporates from health promotion, prevention, intervention, treatment, and recovery. And it's really designed to be person-centered and self-directed, and really catered to the unique needs of each individual on whatever their chosen pathway is to recovery. And I think that's a really important piece to remain mindful of, is that the person that we're serving, I think, is most motivated when they are a part of the collaboration. In whether it's in the beginning health stages and in just forming coping behaviors, or in schools, the individual wants to feel collaborative, and that's the way that I think change happens. And with the ROSC being person-centered, the goal really is, as Rudy's saying, is to integrate behavioral health and primary care in order to build these resilient individuals, families, and communities that support this holistic view of health that's collaborative and attentive and long-lasting. In my role at MVP, I'll be focused on enhancing and organizing the collaboration and communication that we've all been talking about, and I'll be learning from all of you and gathering together those experts in each component of the continuum. I won't be as much the expert in each component, but I will be able to provide that kind of content overview and be able to link together the people that are experts, and have you guys really be a part of knowing what is going on in the areas that isn't your primary field. So that there's that general sense of awareness where we're all on the same page. In the next few months, I'll be identifying kind of that like core team of partners that are experts in their field in order to implement like a pilot ROSC, and see how this integration works. And with that input, I think we hope to analyze and address those gaps that exist and really take action to close them. In one area, just to give like a little shout out, in one area that I think has worked really, really well for integration has been Polly's work in prevention. Everyone that I've met with and the work that I've been doing thus far, your work toward prevention messaging and just integrating prevention and along the continuum has really, really been successful in this region and has really done wonderful things. So that is an area that's been really, really successful. My vision for integrated care is one that's focused on helping people holistically and long-term, whereas, as Rudy's mentioning, where we're all on the same page and where it starts with health promotion, focusing on building coping behaviors and identifying risks, and from a very early age, where if there is an individual who has struggled with behavioral health issues, where we're attentive to their family and their siblings, and it's across the board. I think sometimes it's hard to see change in the work that we do. I came from a treatment background, and I think sometimes it can get hard to see that because we focus so much on our work or on the person that, the moment in time where we're seeing this person that we're trying to provide care for. And I don't think that's necessarily the best way to serve people or to observe change that's happening. Change is really a long-lasting process, and it's more gradual. And in order to truly serve the individual, my belief is that we have to see our work as a part of a long-term and whole person process from health promotion to recovery and healing. My vision is that a person can be taken care of within a system that's knowledgeable about attending to an individual's specific needs, and even if that means identifying where it might not be your expertise, but where to hand that services off to somebody else that may fit better. And I think treating people and their families with this kind of attention and respect can show how a community can do the same in their support of those people.
So we did want to have questions. The other thing I hope that we can agree to is to stay optimistic about this. I've got a new sort of mantra in my life, and it's called, I learned it a couple weeks ago at a session. It's TBU, true but useless. So if we hear, we tried that before, never's gonna, this group, those are all true, but they're useless to getting the solution that we're all asking for. So I think this idea that I hear, and especially Kate and Natalie talking in an optimistic tone, that we sort of had the eye on the prize, and that's where we're headed. And the only thing in our way is ourselves thinking creatively. So I feel very optimistic about the future. It's going to take a while. We talked about our model being evolving because we don't have it right. We're not doing it at full scale yet about any condition. But the fact that we hope to is a reasonable place to start. So questions for any of us about what you've heard, what you imagine, how you'd like to be involved in this evolving work?
My name's Danny Licata. I'm the executive director of the Monadnock Area Peer Support that Jude is also affiliated with. I've been involved in this, and I'm wondering if you have any information about the health home idea that the Cheshire Medical and Family Services and our agency have been working on, and there was a grant associated with it. And I'm not sure, to be honest with you, because it's been a few weeks, where that is at this point.
As I understand, it's still to be announced, but at the end of the month was what we're hoping to hear.
So it's not.
There
hasn't been any updates on that grant yet.
No.
So, but one of the things that I think is important that I liked about this was that right from the very beginning, peer support was considered an important element to it. And we have a dual recovery support group that we do at our agency. I do a support group here. I can certainly vouch for what you're talking about concerns after release. I hear it all the time. And that's a very real issue that I don't think is adequately addressed. But I do think that it's important to, in any model that we're thinking about here, that we do include peer support as one of the primary elements that's being integrated.
Yeah, and I think we heard the word holistic a couple times. I think in everyone's understanding of what the future could be, it's kind of a big tent view. If someone is contributing positively to a problem, we need them all with us, sort of thing like that. So that's a great example of taking what SAMHSA and HRSA would have said was a model which would have been fine to just do primary care behavioral health integration and add the community component to it that you're talking about. And you can think of all the other community players there could be as well. Law enforcement,
Sure.
The schools. And I would say that, I pledge from my position of trying to help you link to the health system that I am always thinking of the more partners, the merrier. I just think I don't want anyone to feel excluded. No one should feel left out because these problems are complex enough that any one individual may need something that one of these partners can provide, and therefore we all need to be in. And I think we're stronger that way as well. I think that when a grant like that is awarded, if it should be, there's support there to support your organization and your work. So I think we also get out of that siloed approach of the hospital writes a grant for itself, MFS writes a grant for itself, peer support looks for money for itself, and that seems like a failing strategy, versus we come up with this holistic approach to the problem and we collectively attract money and other resources to make it a reality. So I think that's a better model. So
yeah, I'm really optimistic because peer support and traditional mental health services have been siloed for a long time as well, even though it's the same population that we're trying to help. And I think we've made tremendous strides, at least in this community, in working collaboratively and together and being able to constantly look for more ways that we can coordinate our efforts. So I'm really optimistic.
If I can touch on it a little bit, I mean, there's sort of two things that I think people have said around the siloed piece, and I like your point, Rudy, of the more people, the merrier. It's about the people at the table aren't. It's not as if anyone here is a problem. It's the system that has kept us separate. The system is siloed. So it's not siloed because we say it needs to be siloed. It's siloed because the funding is siloed. That's right. So to step out of that and to think differently around that is the harder part of it. The quick thought I have is, well, how does the person in the system try to break out of that? But then part of it is that's the livelihood of people in this work. The other side of it, in terms of what you're touching on, in terms of how do all these people and components come together, I was struck by this at one of our broader planning expansion team meetings when a youth, which has been a struggle to get at these meetings, but that youth says, who would one of my peers go to when they are struggling with a social emotional issue at the early stages, or if it's a true mental health crisis, who are they going to go to first? They're going to talk to their peers. And we have to hear that message. And we have to then and take that message and think of how we can then integrate that into the work that we're going to be doing. Because it has to be a multi-faceted approach. And we have to be hearing the people who are affected by this.
Right. And our funding doesn't allow for working with adolescents, for example, where it's 18 and over adults, and I think there's a huge need for peer support programs for adolescents, and Jude can certainly speak to that. You may want to say something about what you've seen as the importance of that as well.
I think the major thing that I'm thinking about and that's coming up for me is this whole idea of silos, and when I'm thinking about silos, I'm thinking about we create these silos with funding and so forth. And I love how you said, let's be optimistic about this. I have so much hope, just based on this panel here and other initiatives that are happening in the Monadnock region. It's not a matter of when, it's not a matter of if we do this, it's a matter of when and how we do it. There is so much hope and so much passion and follow through to address the issue of system of care. But when I'm thinking about this sort of silo idea, a lot of what brings forth silos is our language. How are we talking about people? How are we addressing them? When we're talking about someone who is dealing with an addiction, are we calling them an addict? Are we calling them someone who deals with an addiction or someone who's struggling with an addiction? It really comes back to stripping it down to language. And I can't emphasize this enough because in my experience with being someone who has mental health issues, coming out and being outspoken about that, the addiction that I dealt with was anorexia. It wasn't substance abuse and substance misuse. However, the folks that I'm working with and supporting at Monadnock Peer Support, it's not just people who are dealing with eating disorders. We cover that whole range of folks. So you could see a grad student, you could see someone who just comes in for a group once a month or once a week. But a lot of what stops people from talking about, hey, I have an eating disorder and things are really bad for me, or hey, I'm really struggling with drugs and alcohol and I want to get better at this and I see it as a problem and I see it's holding me back, is the whole idea of stigma. So when I was a teenager, I didn't talk to my doctor or therapist or anyone like that. Like Dennis was saying, I talked with my peers, and so involving youth in a way that supports their confidentiality, that supports the sort of legal concerns around it, being able to talk, for them to feel empowered to say, this is an issue for me, where do I get help, am I going to be punished, am I going to be suspended? These are sort of the practical issues, and just within the time that I've spent, as a part of this work group, and the first presentation that we had with the FAC, someone was saying, maybe we should change our ideas around, if someone is coming to us and we, this is someone who is a an employer, okay? So this employer was saying, maybe we should change our ideas about how we handle things and change our policies about how we handle things when an individual comes to us and says, I have an addiction and I need to get into treatment and I'm worried about losing my job and what's going to happen if I do this and what kind of stigma am I going to face? And so like people were actively thinking about, this employer was actively thinking about, what do I want to change and how could we do this to support the individual? And, you know, I think that is something that's an example of how this is holistic, you know, because it involves, you know, someone's work, it involves their recovery with the recovery supports that Kate is talking about and, you know, that I'm talking about, and it involves the treatment that Rudy is talking about, you know, so that's my thought about that.
I'm sorry that I have to wrap this up. Our time is out, but I think we could continue with this discussion a lot further. It's very interesting, and I do think that hope was the word I heard. I think that a lot of times with the systems the way they are, we have exclusion, and so not everyone is welcome to participate, whether they are in any part of the continuum, prevention, intervention, treatment, or recovery. But now we're talking about inclusion and how can we make everyone feel welcome, wanted, loved, and cared for. And as the professionals in this world and the community piece, how can we all take a role in that? So thank you all for your participation today. I think it was fabulous, and we are recording this, so we'll be able to use it down the road a piece for other people to see. I thank you all for coming today, and I think the panel will be around for questions afterwards. So thank you all very much. Thank you.